Yeah, I think we can continue with the Medtronic Symposium. The name is Innovations in Bifurcation Treatment, and it's a really pleasure to be here with Dave, Marek, and Francesco. I did not like that sign to reduce the rate of kissing, but Francesco may help us come back with some data from in vitro testing. So we will discuss how in vitro testing in Visible Heart Lab in Minneapolis actually has significant impact on our practice and transforms the pitfalls that we learn in the visible heart in the proper way to perform technical steps. And Francesco is really a leader among EBC members connecting EBC with the Visible Heart Lab. So, Francesco, pot, side pot, pot, kiss, pot.
Honestly, I do not know if, I mean, you are too kind with me. Anyway, what is very important, I think that we discovered it once more during the previous session. It is important to have in mind the concept that bifurcation intervention and stenting is a situation where we start with something and it can become unpredictable if we do not follow the, let's say, the steps. So stepwise provisional is very adaptable technique that allows to implant in the case of need. Second stent, for sure, it allows to treat the side branch in different ways. And among the different ways, what has been discovered that pot and kiss, something that still is practiced in trials, like we discovered now, is associated with different amount of deformation in the main vessel proximal that is completely unpredictable because it is related with how the two balloons for kissing are overlapping into the proximal main vessel. So for this, there is the invention of a simplifying methodology that is pot side pot, that is, according to bench tests, very able to allow the proximal part to maintain circularity and while having expansion of the side branch. So it seems really very easy and effective in the bench test. Then we have the possibility to restore the distortion that is induced by KISS by performing RPOT. And we know that with last generation drug-eluting stent, it is very suitable to have this transformation that make the stent probably very close to bifurcation dedicated devices. So on top of this, what happens is the fact that according to the suggestions by the EBC, pot kiss post and pot side pot are the two best provisional sequences in the case of side branch treatment need. So this is actually the status. So the Krabbis trial was probably my dream. The condition where instead of having bench tests, we start with a new way of performing tests before having clinical phases. And this was done with the aim of to compare the stent configuration obtained by PCI practice using different side branch optimization technique after main vessel stent implantation in large bifurcation. So we are dealing with large bifurcation where the distortion might be large. And the two sequences are the best one, post-kissing pot and pot side pot according to bench test that we tested. Why was my dream? Because instead of having bench test and then clinical practice, there was the opportunity to have a preclinical phase into the Visible Heart laboratory before embarking into a clinical phase in my hospital. So the preclinical phase has been performed by practicing as, operators on radioscopic guidance the technique into the Visible Heart lab, and thereafter the after this confirmation of the safety, there was the possibility to come with the clinical phase. I think that it is really the way to go in the future for technical refinements. So the flow chart was this, I remember. This is provisional stenting, the stent crossover. Sorry, this is, I think it is the battery has gone. So crossover stenting size according to the distality. Then, can you give me something working now? So are you going for me? Okay, okay, okay. So after crossover stenting, POT has been done with meticulous attention to reach also the proximal part of the stent and the carina, and then the patients were the bifurcations were randomized to either pot kiss pot or pot side pot. Are you? This is a similar activity. Okay, okay, that's good. So thereafter, we know how important it is for provisional flow to perform distal rewiring, and it was done with the beating hearts at the best of the capacity of the operators. Then kissing balloon or the side branch with small protrusion inside the main vessel and small overlap in the case of kissing, and the re-POT to correct in both. So in the case of the preclinical phase, multimodality was performed, including angioscopy, OCT, and micro-CT, together with angiography that guided the procedure. In the case of clinical phase, only OCT was performed. So these are the preclinical study endpoints. We selected as primary endpoint the minimal stent expansion at the distal main vessel. Why? Because we know that in the case we dilate the side branch, we will create a carina shift into the distal main vessel, so that in the case re-POT balloon will not reach that area, we will have a penalization for pot side pot. And then secondary endpoints were, I mean, all the other aspects, including the eccentricity, so the circularity measured into the proximal main vessel. The stent that we selected was the Onyx stent, that is very suitable and very well tested in the bench test as adaptative to the provisional stenting. And the final results have been presented last year. So I recap for you. What was incredible was to see that into the visible art, the procedures were performed exactly in vessels that resemble the left main, large bifurcation, 4.2 millimeters into the proximal main vessel, 3.5 in the distal main vessel, and 2.6 to 7 into the side branch. And the devices followed this, so all the balloons and stents were exactly like expected in human left main interventions and large bifurcation. And regarding the results, I can share with you what happened with these two modalities in representative examples. You have on top the line pot-kiss pot as evaluated by angioscopy, OCT, and micro-CT, showing you the result. And with pot side pot, what is evident that at the carina, it is possible that you are not able to perfectly correct the distortion that induced at that level with the side branch dilation. And regarding the proximal the polygonal confluence and the proximal main vessel, what is apparent here is the fact that you had two main important aspects. The first one is the fact that with kissing, you have this longer protrusion that can be seen by both micro-CT and OCT toward the main vessel. However, you have a circularity that is more preserved with the pot side pot. So, and this is also confirmed by the measurements performed by the two modalities, showing that in the distal main vessel there is a significant improvement with pot kiss pot. So overall, this first part was the first prospective randomized trial inside this unique preclinical environment. Bifurcation PCI conducted with PSP and PKP achieves different stent configurations that are acceptable anyway. PSP has better preservation of the circularity in the proximal main vessel, but PKP has better expansion and position at the level of distal main vessel, as well as better side branch scaffoldings. So on top of this, we embarked in the second part of the study, that is the Krabbis clinical trial. It is monocentric, no profit, and randomized and no sponsored, honestly, because Medtronic did not support it, honestly. So, but we really wanted to go on with this project, so it is recorded in clinical trial. And we planned to enroll 60 large bifurcation, very large bifurcation, treated by provisional. And the patients were randomized, 30 and 30, and the clinical exclusion criteria were mainly the one of elective trials in the field. And regarding the endpoint, on the basis of the results of the visible art, we designed a superiority trial having the minimum stent expansion at the distal main vessel as evaluated by OCT for the trial. So the current status, unfortunately, I failed to give you the final result here, because we are actually enrolling 58 out of 60 patients, and all of them are mainly unprotected left main lesions, mainly treated by the Onyx drug-eluting stent, because when you see these images, you want to use the stent that performed so well in the visible art. And I want just, however, to share an example of what we are learning from a trial like that. So this is a case that enrolled in the trial. The patient has been randomized to pot side pot, and the operator did his best job to have this result. It can be acceptable, but I mean, we know that it is important to perform OCT and imaging, so the result was like that. We can accept as a good opening of the side branch. However, you see that in this area, you have some indentation into the distal main vessel that probably can also be recognized here into the image by angiography. So, and the other aspect is the fact that here there is no scaffolding like I showed at the end of visible art lab interventions, and MSA is 5.0 with expansion of 75% for distal LAD. So the operator decided to perform pot kiss pot to try to enhance the result. This is angiography, and this is the aspect, so the side branch is basically the same. However, what we see here is a different conformation with the stent struts producing much more toward the side branch, and here at the level of the distal main vessel we increased, reaching an expansion that is really optimal. So to me this is a very provocative case, and for sure it supports the concept that in the case we need to implant a second stent, this condition is much better because allow you to have no much protrusion inside the main vessel. Thank you for your attention.
Thank you, Francesco. Francesco, if you cross distally in both groups, how do you explain longer protrusion with kissing compared to balloon inflation towards the circ?
So I don't think it is a longer protrusion, honestly. If you come back to the case, There is basically the length of the protrusion is unpredictable because it depends on how the last ring that can be crossed is over there. The problem is that when you perform the side branch dilation with large balloons, we know that we have the possibility to have two kinds of distortion. One is the fact that we stress the other part of the vessel, so malapposition on the other part of the vessel, and this is corrected by the balloon that we add for RPOT. But there is also the possibility that the carina shifts the soft carina, but also the stent struts, and the stent struts will be corrected in the position only by kissing or by the nose of the balloon for POT. But this looks a little bit unpredictable. So there are some cases. The last one I did on Wednesday, in which pot resulted in a perfect result, because I was probably able to reach with the nose cone, the nose, really the carina. But I mean, in a beating heart, sometimes you fail.
Dr. Shaban?
It could be, corrected this or prevented the deformation of distal part of the stent by using underside balloon for side branch?
Probably yes. This is why, I mean, we think that the use of aggressive technique, let's say aggressive, things like kissing and POT repeated should be applied and considered as a value only in big bifurcations. I mean, they are considered to have really optimal results in big bifurcations.
Yeah, actually, that could be a good reason to use large balloon in distal left main. But non-left main bifurcation, I think, using a smaller balloon can avoid the deformation of the stent.
Yes, I'm quite sure that this is the case. And also shorter balloon, there are Japanese data showing that even a shorter balloon, at least in bench tests, are able to be effective. But for example, 8 millimeters balloon, are we able to be precise in putting there all the time in ostia that sometimes are not visualized perfectly?
One short question, and then we have to proceed.
Just a short question and remark. I think the fascinating pictures, Francesco, you showed for the preclinical phase. And for me, I think it's going to be a very important study to show the differences between pot side pot and pot key spot that we probably tend to believe in more. Now, from the preclinical phase, we know that for long term, the side branch osteum might be going to tend to have some restenosis or some failure in the long term. And you showed that that's probably the most important, that for pot key spot, you have a better coverage of the whole bifurcation. And that's what's probably going to come more important than the proximal vessel, that pot side pot you do, because you can correct that with the repeat pot. Am I correct?
Yes, I mean, I want to stick to what we are telling. So this is a mechanistic study trying to evaluate which is the best acute results we may achieve with the technique of provisional. And this is convincing. I can tell you that it is what we also discovered is the fact that bench tests have carinas that are not able to be directed and shifted. So in the human, as like into the visible art, what we have is carinas that can be displaced. And when we displace the carina with metallic parts over, this translates in a deformation that needs to be corrected, that is probably more important than the one that we thought in the past, that was the malapposition induced on the other side of the main vessel. Yeah. This is my take-home message.
Thank you, Francesco. We look forward to see final results, and I would like to invite Dave. Thank you, Frank. Journey about DCB. I think we painted the whole meeting with DCB. So
we have, absolutely. Right, so I'm just waiting for my slides to arrive. Nothing's happening. It's not under my control.
You can, yeah, you can start the journey before slides.
I'm ready. Hooray, hooray. Right, drug-coated balloons. My journey with these. Okay, so stents. They're really great when you need them. But, as many of you will have heard repeatedly during this meeting, people have developed nagging doubts about stents and when we should use them. I won't go back right through the evolution of when we started to use them, but they were a bailout technology which has then become a completely mainstream technology. So what was our experience? Okay, well, we would still see acute on chronic or acute stent occlusions happening, maybe a year, maybe 10 years after stents were implanted. It wasn't a thing that had gone away. And some of those were really bad, really difficult to deal with. The data that accumulated suggested that there was a 1 or 2% year-on-year MACE rate related to these stents. So intuitively, you couldn't really think, okay, this is a benign thing we're doing. No, if you place a foreign body inside the coronary artery that's going to be a permanent fixture there, that's not a benign thing to do. There must be some downside to it. And on a practical front, it's really difficult sometimes to balance the difficulties of, well, yes, this patient is now bleeding, but they only had a stent put in the proximal LAD 2 months ago. Okay, how are we going to balance those risks? So for very many reasons, I think I just went an overnight complete volte-face, a Damascene conversion. Essentially, my mental approach, it changed from I'm going to place a stent. How long is it going to be? How big is it going to be? How many am I going to place? To, I won't place a stent unless I need to. And this was one of the cases that convinced me that this was important. This was a man who 10 years previously, when he was aged 37, came with some angina and had treatment to a, 70% distal right. Okay, maybe it was the cause, I don't know. I wasn't there. And the operator didn't do a very good job. They put one stent in and missed it slightly, as people do. And so they put a second stent in. And then it looked quite nice, and they thought they'd done a great job. 10 years later, he came back with an acute coronary syndrome, and this is how it looked. And I was in the other lab, and there was a senior fellow doing this, and he called me, and I said, yes, okay, fine, so, wire it, pre-dilate, you might have to work quite hard looking at it, imaging, and then we're going to end up doing drug-coated balloons to this thing, okay? And he started off, and he was a pretty good operator, and it was clear that this was actually quite nasty. It was a bit like granite inside this stent, and he had to use a corsair and was winding it through. And once he'd done that, it was hard to inflate. He had to use, I can't remember exactly, but cutting and then non-compliant balloons. You could see the guideliners right down by the start of these stents. And in the end, he did, the best he could and put in a massive stent. Now, that's fine, and the guy's got a great result for now, but age 47, he now has 3 layers of metal. It's rigidified his entire right coronary artery. I mean, this is a tragic artery now for him for the rest of his life. That is like a sort of metal explosion down there, and you just know that granite, that inflammatory process is just going to carry on, and he's going to be back, and it's going to be really difficult to treat. So that was one of many cases that made me think, it's just not right. We're just bunging in stents and make it, it looks pretty now, but what's it going to be like in a few years' time? So I started doing, cases with drug-coated balloons and thought, okay, am I sure? And it was really helpful that there was a clinical trial going on to be participated in. And so this was the kind of thing we started with. Somebody's getting angina. What would I have done before? I'd have probably placed a stent from the proximal LAD to about 3 miles down the LAD there. And then I might have just ignored the diagonal because it was a bit awkward because it's behind all the stent. Or I might have done a kiss, I don't know. But anyway, I didn't do any of that. I just did a little bit of dilatation and drug-coated balloon, and it didn't look too bad. I could sort of see a faint dissection in there, which was encouraging. And then same on the diagonal. It doesn't look beautiful, but it was actually clinically perfect. No stent, thank you very much, no angina, no problem, no antiplatelet issue, no problems with long-term difficulties with stent to your proximal LAD. So, you know, I'm going to get rid of these last slides because we're a little bit short of time, but suffice to say I started doing it everywhere, and I'm very happy with it because actually the results have been really good. So this was actually I'll tell you now, this was a STEMI, and I thought, well, this is a great place to do this. Aspirate the clot, give some strong antiplatelet agents, because we always get the size wrong in STEMI, and we know we do, but we still stent them. And that was at the time, and then this was 3 months later. So, you know, the vessel's quietly got bigger all of its own and isn't impeded by having a metal structure of the wrong size in the middle of it. So, in my early days, I've learned 3 things from this, and I will be telling you to suck eggs here, but 1, dilate the vessel properly, 1-to-1. Patrick, in fact, wrote a lovely editorial in CRM, I think it was, basically reminding us that angioplasty is dissection. That's how it works. It's not footprints in the snow. If you haven't dissected it, you haven't done it. You haven't done anything. You've just sort of annoyed it slightly. You've got to dissect it to actually make a difference, open up the blood vessel and get a result. So I learned that, and I learned TIMI3 flow is really important. If you have TIMI3 flow, then you can be forgiven a great deal of other sins. It doesn't matter if it's ugly, so long as you have TIMI3 flow and you don't have either a spiral or propagating dissection or an occlusive dissection or some version of dye staining in and around the artery. And thirdly, the balloon is not for dilatation, it's simply for application. It's just to apply the drug. Don't use it as a dilatation instrument. And I would say to anybody who's thinking about it, try it. You might like it. Thank you.
Yeah, great talk as always, very inspiring. Francesco, you have a question.
You are a talker that is so nice that I cannot accept that you are so nice, and I will give you a bad question. So, since I remember why my teacher told me, my master told me that we are using the stents, that is because they had all the night to have the fear to be cold because there was acute occlusion of a ballooned vessel with a plain balloon, because at that time there was a risk of acute occlusion due to the evolution of dissections that were classified at that time exactly like we do now, and were accepted where now it is proposed to accept for drug-eluting balloon. So why you, as operator, think that there should be no risk of acute occlusion of these dissections we leave?
Yes,
with drug-eluting
it's a very good question. I think it's not that there's no risk. Of course, there can be a risk, but actually, for some reason, the risk is much lower. And other people will be better to answer this than me. What I think, personally, is that what people had before stents was they had no bailout option other than surgery. So they were actually relatively timid with their angioplasty. And it was that very timidity which got them in trouble, because all they'd done is abraded the lesion without dilating it. So, you know, I worked for somebody who did a 2mm balloon at 2 atmospheres, 4 atmospheres, 6 atmospheres, you know, incredibly timid angioplasty. And there were problems. And actually, it's only when you've done a proper dissection of the vessel that you will actually get, okay, now we've got good flow, now we're much less likely to have occlusion. I think the antiplatelet agents that we have now that are much better as well, and others will be able to answer why. All I can say is that my personal experience as well, which is helpful, has actually been really reassuring. You know, I've had one case come back in a year, and that was because I did too much really in a STEMI case, but only one, you know, out of all the cases I've done. So I'm really reassured.
Dave, wonderful topic, lecture. What is your approach to achieve controlled dissection? You need dissection.
Yeah, absolutely. So I mean, it's one-to-one ballooning, it's liberal use of cutting balloons, scoring balloons, whatever. Actually make sure you can see a visible dissection and then think, okay, now maybe I've actually dilated this properly.
Yeah, I mean, first we have to remember that when we did balloon angioplasty 79, 80, 81 and so, there was only aspirin on board, nothing else. So that's the big change. And don't forget the diclopidine who came from Marseille. At the time of the stenting, the guy was giving diclopidine the day before the balloon angioplasty. If he had to put the stent, the diclopidine was on board. What was his name of that? Baragan. Yeah. Baragan. That was the big change. Now, what we have seen is in 95% of the case, there is a fracture. And the fracture is always at the smallest, thinnest part. We have measured that very precisely, 372 micron. That's where to get the rupture. Not at the site of the plaque, not even the edge of the plaque, what I was expecting, but just at the small part, the most weak, the weakest part of the vessel break. What you see on OCT, and we are still working on it because it's frame by frame by frame, and AI is not yet there to measure the small thrombus. Systematically at the tip of the two edge, you see small thrombus, probably platelet, because there is no shadowing behind, but no consequence, absolutely no consequence. I would say this one will be in trouble. No, he was not in trouble. So also a little bit thrombus is part of the phenomenon. It's difficult to make the difference between the thrombus with shadowing, the thrombus without shadowing, but thrombus is there in a small portion, but no acute obstruction. Now, everything you said is beautiful. I mean, it's really the way we are thinking. It's the good sense. It's down to earth. I mean, I love this kind of talk. One thing that I'm missing terribly, terribly in all this meeting on the DCB is that you don't cage the vessel. Thus, you have to start post-DCB a maximum therapy. That's what you have to do. You know, you will see very soon a paper where we put together two studies, multi-talent with the supraflex cruise and Pioneer with the Sinomet stent healing and so. That's all about 4,000 patients. You know how many patients are below the so-called level recommended by the guideline? 15%. So you have access to the plaque with powerful atherogenic drug, but you don't see that systematically in the protocol. This is the moment to try to predict rosuvastatin 40 milligram and ezetimibe in one pill. You have that. That's Sanofi, the Zimpas. That's one pill in the morning. That's it. If it doesn't work, you have to go to your lipidolog and say, guy, I'm giving rosuvastatin 40 milligram and ezetimibe, but it's still with 75, 100 milligram of LDL. And then you will have the permission to use the inclisiran, for instance. Inclisiran in our population in Europe is less than 1% today. Less than 1%. We have done a paper with Tom Lucia to say, where are the guidelines? Who is applying the guideline? Not the interventional cardiologist. And the drug-coating balloon, that's the reason why you have to go full speed with medication, I think. You know, it's quite interesting. In a public meeting in one of these, you know the LDL of Bornwald? 27 milligram. 27 milligram. I don't know how he reached that. You know the LDL of Yagat Narula? Everybody knows Yagat Narula. It was 21 because he was jealous of Jean Bornwald. and the last meeting publicly he said, you know what, Patrick? Now my LDL is 7 milligram. I said, Yagat, pay attention on hemorrhagic stroke. I mean, it has been described. So he's back to the 21 of 27. But it tells me something that it can be done. And you know, in China, the Lin Tao, Professor Lin Tao, we did this big trial on DCB publish in the Lancet and present at ESC. They are planning 10,000 patients where they have 0.8 millimole for LDL versus 1.4. 1.4 is 50 milligram. So they will go to the 25 milligram. I think these guys are in the right spot. I mean, DCB and very, very aggressive treatment. Then you will not have what we all fear. There is a piece of metal for 20 years with neo-atherosclerosis and all these things. That's the way to go. And you know, Gunzig for a certain time used to say, I'm a dentist, and then he stopped to say that. But initially it was his dream. His dream was to maintain the patient in the one vessel disease. You do the right, you do the left, you do the circumflex, but you stay in one vessel disease. But you have to have drug to help you, yeah? Because my generation, the growing generation above 70 years, if you look at the pyramid of age, that group is augmenting every day, 70, 80, 90. The birth get reduced, and the working capacity, working people get also reduced. So that's calcified. That's maybe beyond anything called regression. But the generation which is between 20 and 45, that's the only generation Valentin Fester is talking about, because you can get regression and you don't put metal in these people. That's the message of David. And it's the Damascene scene. That was David or that was Simple? Oh, wrong name.
Fernando Alonso.
Yeah, very short, very nice and stimulating presentation. Fully agree with that. But let me play a little bit of David's advocate, right? So that if you go to the guidelines are very clear. For the novel lesions, you need to put drug-eluting stent. This is 1A. In the last guidelines, in the recent guidelines, now you got even in the chronic coronary syndrome guidelines that even for ISR, they recommend drug-eluting stent versus bare metal stent. Well, this is what we got in the guidelines. Then you got all these studies, randomized or observational, in de novo. We performed some, but they and the results are, you know, for selected patients, where the two strategies are very appealing. Inexperienced people, TLR, which is the main primary endpoint, is similar. So this can be done for sure, but there is a bias. And then we learned very recently that this is the recent Chinese study published in Lancet, say that non-inferiority was not met. So having said all that, of course you can do that, but why should be doing that? I mean, your interventional cardiologists don't have the experience to, you know, see dissections. They go there, they use optical coherence tomography, and they see terrible things. So this can be done, but this is against the guidelines, I will say. Yeah. And how can we push the field forward, but not just saying, well, it will be great, not using metal.
So if everybody
I have to intervene here because I know the story behind. I mean, the story behind is Charlie Gao was a fellow together with 7 other fellows from China, and we planned that trial, KH1, 4 years ago, with a lot of interesting things, which is preparation before randomization, etc. And now Charlie Gao is busy these days with a huge amount of letter together with the Lancet saying that paper is misinterpreted. I mean, this is a remarkable paper. You have 2,600 patients. The half of the population is below 3 millimeters. That's what we do in the lab, below 3 millimeters. Look in your database how many times you use a 2.75 of a 3. And only the half of the patient is above 3 millimeters. Above 3 millimeters, you see a kind of catch-up. Maybe we will not aggressive enough with the drug-coating balloon. That's my point number 1. Because it's not immediately, it's after 6 months, 1 year that it comes back. And below 3, perfect. As good as the death for 1 year. So there is in the media in China misinterpretation of the data, and Lancet was so upset by that that they wrote a letter to us and said, you have to correct that publicly in China. So that's what we are doing. We have been writing to everybody to say this is not a negative trial. This is a trial showing that below 3 millimeters it's a good treatment, above 3 millimeters. And of course it's categorical as usual in medicine. You have to find a little bit the way in between. But that's very important because, you know, key opinion leaders like Fernando is telling us the guideline make the wrong interpretation. No, they should clearly set, as long as it is below 3, you can do it 2 years. It's not 10 years. We discussed the 10 years yesterday, but 2 years is okay.
I think we should close this session. Definitely extremely interesting and important, and this is why EBC is really special. Thank you very much to speakers and to all of you.